Hi, my name is Tamara. I'm from Atlanta, Georgia, and I am a multiple myeloma thriver.
Hello, I am Alston. I am originally from Charleston, South Carolina. I reside in Atlanta and I have amyloidosis.
We had some questions about blood and bone marrow conditions.
So we sent those questions to Dr. Rosenzweig.
So we're about to see how he responded to our questions.
I think the reasons that there's an element of distrust among Black patients with the medical community, with doctors, and with perhaps especially white doctors, is because of the history of racism that has been a major part of this country's history. And there has been that history in the healthcare world, as there has been in other elements of our history. And the big example that we all learn about as a reason for that distrust is the Tuskegee experiments on syphilis, where it was an amoral decision to follow predominantly Black patients with syphilis to evaluate the natural course of the disease rather than to treat those patients. And that has created a history and an element of distrust among the Black community. And I think that that's a barrier we in the healthcare community are very much aware of and eager to overcome.
He said it though. I'm like, there is a distrust, right? That the Tuskegee trials or whatever experiment, definitely, and then just the history of our country.
Right.
But I really appreciate what he said at the end, is that doctors really want to overcome that. We need to have an awareness, like we need to admit, what the reality is, that there is a mistrust. And so understanding that there is a distrust or mistrust, what are we going to do to try and overcome that?
There absolutely is a distrust, and it does go back throughout the history.
Mm-hmm.
However, I would like to know exactly what they are doing to overcome that. What discussions are they having, and are they able to put the information out there, or the programs or the videos, to say, hey, we know this is happening, but we want you to know we are working at that. And if you work on that in the medical field, then hopefully that will transcend throughout their personal lives.
Right.
And, we can create a change in so many different ways. And at the end of the day, I think that when you're treating someone and someone is sick, there should not be any color barriers.
Right.
But I think you have to show someone what exactly it is that you're doing to work towards that goal.
And I think that's the
help.
That's the next question is, what are you doing? What does working look like? What does working to change this perception look like?
What actions?
Right, yeah.
I do think that racial bias can impact just about all of our decisions, and we have to be aware of our racial bias when interacting with patients and when making clinical assessments. There are certain comorbid conditions that happen to be more common in certain races, and that can cloud a physician's judgment when thinking about diseases and attributing diagnoses.
I mean, that was fair. That was, I felt like it was an honest answer, and I feel like it was, he took a while to get to it, and I believe he was wanting to be very intentional with his response. The fact that I'm just glad he didn't say no, because that to me would have been a flat out lie.
Absolutely. Absolutely.
So it confirms, I just wonder how many other doctors would answer the same way.
Well, I think that all of the doctors, I would hope anyway, would answer basically the same way. What I will say is, as a patient, I'm not thinking that doctors are stereotyping, oh, this is a African American or a Caucasian or Asian or whatever disease, and looking at the person, because at some point we all have crossed paths within our chromosomes and DNA. So It's like, well, I understand that, but you really have to take that out of the equation, and you have to diagnose based on the symptoms. So I'm hoping that all doctors are looking at it that way.
I think it's a good hope. I just don't believe it's how it works, though. I think that you have to acknowledge that, yeah, we do have biases. So therefore, let me not sit on that bias. Let me go a little bit deeper and go outside of that. That's what I'm hoping is what he was saying by saying we acknowledge there are biases. But I personally feel like I've seen where doctors acknowledge, that we are different, that, that there are differences when it comes to race. And sometimes I feel like they just stick with that.
No, I'm not really aware of a bias against Black patients in particular that they have to prove that they're sick rather than just state their symptoms and present their complaints. I think that it's important for doctors to have the time to listen, to spend time with patients and hear the entire story and accept what patients say as the truth. There's no barrier of proof that needs to be provided by any patient, Black, white, or otherwise.
Do you have a comment on that one?
I do have a comment, and I think that he personally may not have that experience, and it may be due to his clients or his patients' ethnicity. However, it is absolute true that there is a disconnect in that area. And also, I think it transcends down to the staff. I don't
Right.
think that someone wants to just say that they're sick and they're not.
Right. Yeah.
Or maybe it's a articulation barrier where they're unaware of how to describe what they're actually experiencing. But
Yeah.
they may know something is wrong
Right.
and they
Yeah.
may need help with that, but it's a fact.
It is a fact. It 100% is a fact. When I go see my doctor, I really have to, have thought about it really well, like you said, just to make sure that I'm saying it correctly. I have to think about it. And to me, that puts a lot of burden, I think, on patients sometimes. Because if you're not feeling well, and then you feel like you have to make sure that they understand you and that they believe you, that's just, I don't know, that's just so heavy. That's just so much weight.
That being said, it's important to know that diseases like multiple myeloma and amyloidosis do in fact have a racial predisposition. So thinking about race when making decisions and when making diagnostic assessments of patients does weigh into the decision-making tree.
That felt, I don't want to say standard, but I mean, that makes sense to me. If there's a predisposition, then they take that into account. I would hope so. So I don't have a big reaction for that.
I think that in a doctor's response, especially when they're being filmed and things like that, they have to kind of bite their tongue a little bit, or not necessarily bite their tongue, but be mindful of the words that they're saying due to repercussions from patients or legal repercussions. And when you're asked questions like that, sometimes you may forget your practices that you have had. So I think they have to be calculated in their responses.
Oh, yeah.
But I think it's a personal character within you, whether you're doing it the right way or the wrong way.
So patients with amyloidosis are quite often misdiagnosed with another disease. And the reason for this is that the symptoms of amyloidosis are very nonspecific and often mimic other more common conditions. For example, neuropathy can mimic diabetic-induced neuropathy. Heart failure can be caused by a variety of causes, not just amyloidosis. One of the most common symptoms of amyloidosis is fatigue, which is often attributed to other more common causes like endocrine abnormalities or even just lack of sleep or depression. And so it's very common for patients to be misdiagnosed with other diseases. In fact, many patients with amyloidosis end up seeing multiple practitioners before the diagnosis is finally reached.
Was that your experience?
My experience was my experience was not that. I don't initially think. I think what happened was someone said, "Hey, let me test you for." So no one ever brought up amyloidosis to me prior to. They were always treating me for congestive heart failure. I've had symptoms of lupus, so they diagnosed me with that. So now it's like I'm wondering, okay, did I ever have lupus? Or because I've been in remission so long, so it's like, did I have lupus or was it amyloidosis
The whole
entire
time.
time?
The entire time.
So if it wasn't for the doctor checking and saying, hey, yes, you have this genetic disorder,
Mhm.
then I would have never known about it because none of the other doctors ever mentioned it.
Yeah. And I'm sitting here listening and I'm shaking my head too because, like I said, I have a friend who was recently he was diagnosed, and it was probably 2 years after he first started experiencing symptoms.
Yes.
And was being treated for clearly something he did not have. And so it's just, I don't know. It sucks. It hurts my heart.
It does suck. And I wonder how the medication that they prescribe you for one thing affects the actual diagnosis. Is it causing more harm than
Right,
not?
yeah.
So it's like, how does that work, and what are they doing moving forward to, change the narrative of the misdiagnosis with
Right.
people?
Hearing him say actually gives me a little bit of comfort to know or to understand that my friend's misdiagnosis is actually common. Because
Wow.
we were really thinking that there's some negligent doctor out there
Right.
that just kept making a mistake over and over again. So to know that it's a common misdiagnosis, I don't know, gives me some peace or some relief, right?
Right.
And I don't feel as disappointed. I mean, it's still disappointing, but it makes more sense
Right.
now.
As to the reasons why that occurs, we really don't know. There is a lot of research going on into the genetics of multiple myeloma, but we haven't come across those answers just yet. As to the reasons why multiple myeloma may be more deadly in patients of color rather than in Caucasian community is really a complicated question and likely multifactorial. And in fact, what we've learned is that while patients who are African American do have a worse outcome compared to Caucasians, if those patients of color have access to the same treatments and the same novel therapies and aggressive treatments such as autologous stem cell transplantation, the outcomes are actually equal, if not better, for African Americans than the Caucasian community. And so while the reasons are multifactorial, I think access to care and access to the newest therapies is a major contributor to that.
I'm in agreement. I mean, he's talking about multiple myeloma, so that's the disease that I'm living with. And I've heard over the years, right, that African Americans tend to fare better on treatment than some of our counterparts. And so, but why do we still have worse outcomes? And so from my estimation and from the people that I've met over time, I believe that access has a lot to do with it. And I equate race to that. I think when you're living in a metropolitan city like Atlanta, there's a huge population of us. Fortunately, we have access to those doctors that specialize in that. But I really do believe that if I lived maybe in a rural area, and I didn't have access to the novel therapies, like he said, then I really do think that my situation personally would be different than it is today.
The main objective of a clinical trial is always to improve the standard of care for patients. However, clinical trials have different phases. In a phase 1 clinical trial, the objective is to find the safest dose for a patient to take of a particular medication or molecule or intervention of some sort. In a phase 2 trial, the goal of that is to see that this intervention, this treatment, has benefit for the patients. In a phase 3 trial, the goal is to see if that intervention is better than the standard of care and is often compared to either a placebo or the standard of care with the goal of finally getting that treatment approved and used for the general public. With all that being said, a clinical trial is always evaluated very carefully to be sure that the investigation itself has some benefit for the patients and has a low risk of doing harm.
Okay. I always like to hear, their thoughts around clinical trials and the reason behind and the value of them. And I mean, it makes sense. It's I've been a part of a clinical trial, phase 1, phase 3. And it's funny though, like when you hear that the phase 1 is when you're trying to figure out the dosage, and then the 2 is, how effective is it? It's funny that those two aren't together, right? We're talking about a dose, which, is it going to be small or is it going to be big? Not so much of, I guess they're considering how effective it is too at the same time. But hearing him say like it is about dosage, I agree with that because I just got out of one. I'm actually still in a clinical trial.
Okay.
Of phase 1, and that dosing situation was cuckoo. It was a lot.
It was a
lot. Yes, it was definitely a lot. But that's interesting though, right? Like the dose and then the effectiveness and then comparing it to the standard of care. That's interesting.
My approach with the clinical trial, I think, is different because I have worked in the marketing research side of it.
Mm-hmm.
And I think that there needs to be more regulations and monitoring of the actual clinical trials to ensure that the people that are taking the medication, that are supposed to take the medication, actually are taking the medication,
Mm-hmm.
because someone else's life is on the other side of what you say is going on.
Oh yeah.
So I think clinical trials are absolutely needed.
Mm-hmm.
I think it's a great thing. And in hindsight, I also think that there needs to be more regulations with the companies to ensure that what the people say that they're doing, they're actually doing.
An entire patient's health and support system and socioeconomic background are considered when choosing treatments for our patients, regardless of racial background. There are some treatments that do require a lot of support from family or other members of the community. And if a patient does not have that support system, we can often work to find that support system, but it has to be considered as part of the big picture when choosing our treatments.
Okay. That's interesting. That's good. I mean, it makes me feel comforted in knowing that, race does not play a factor. They do look at socioeconomic, but it's just a standard, I guess, thing across the board, regardless of race. But yeah, it sounded like he was saying, like, they look at, like, if this sort of ailment is going to require you to have a lot of support. They look at, does this patient have the support? Somebody, I guess, to do the heavy lifting, to administer medication, whatever that might be. So it's good to know that they do consider that and that they will, try and offer services to help that patient if they don't have the support. So that's comforting.
I agree.
I think that the best way for a doctor who's not particularly knowledgeable about a disease like amyloidosis or frankly any rare disease is to seek help from experts around the country or maybe even around the world. It's important for patients to have access to specialists regardless of the disease or the condition, and for patients to work with their physicians who are willing to partner with other specialists. Medicine has become very complicated over the years as our knowledge has increased. And so a generalist can take very good care of patients without question. But when the disease is rare, like amyloidosis or another rare disease, it's very important for there to be a partnership with another physician or another caregiver who really focuses on that particularly rare disease. In today's day and age of modern technology, those kind of partnerships are readily available.
Yeah. I mean, it seems basic, right?
It seems that way.
That, if you're a doctor or physician and you are responsible for people's care, that you yourself would want to expand your knowledge, right? So that you can treat your patients better. But I have heard of some general doctors or just primary care doctors maybe not wanting to partner with specialists. I unfortunately don't have that situation, but I have heard of that. And that's odd. Like that's bizarre. That puzzles me, that if you're both in the, medical industry or medical field, that you would want to collaborate and partner, and make sure at the end that the patient is the primary focus, right? Regardless of egos, or regardless of, I don't like this person, I want to work with this person, or I'm a specialist, they're a generalist,
Correct.
You're both doctors at the end of the day.
I think that there should be, let's just say, like a national database to say, hey, these are the rare diseases. These are the symptoms. So maybe the specialist can input something somewhere. And if a doctor is writing up your chart or your summary, and some of these keywords or flag words come in, then it will populate something to say, hey, this mimics this disease.
Right.
Maybe you can reach out to the person on the chair board, or this doctor in Washington, D.C., or this doctor in Alabama, or this doctor at MUSC in South Carolina, whatever the case is. But there needs to be something where it's easier for the doctors to assess, instead of pushing it off to the patients to try to find someone.
Right.
Or you're getting the runaround, because as a patient, I know as myself, I don't know how much time. You're kind of like in panic mode. I don't know how much time I have, and how do I get there? Is my insurance going to cover it? It's so many different factors. And then maybe they can have it where this insurance covers this insurance covers that. Just kind of make things. We're in a technology world, and there's no reason that every doctor does not have access to a specialist, medications, rare diseases, that they're not aware.
I agree.
In this age.
Thank you, Dr. Rosenzweig.